or they are restrictive. And that helps us define where the problem lies in our patients. Okay. We also talked about, when we were doing my first lecture, we talked about tidal volume. I talked about tidal volume when I talked about the PCO2. We talked about that, how it relates to rising PO2. Does anybody remember that? Say yes.
Yes.
So when we are sitting quietly, the air is in and out, and that is passive process. In the sense, we are not aware of this. In general, a healthy person will breathe out around 500 cc of air at every breath. At every breath. It's around 500 cc. As you know, we are different. Height, age, and sex. Three variables which affect our lung volumes. Height, age, and sex. These three variables do affect the actual lung volumes. But give and take, most of us are between 400 to 550 cc. They're very tall, and then thoracic cavity is big, and chances are you have a high tidal volume. Smaller, very smaller tidal volumes. So in general, a normal tidal volume is around 500 cc. Give and take, it can be from 400 to 550 cc, depending upon height, age, and the sex. Now, take a right hand, everyone, take a right hand. We did these exercises before. You put it in front of your mouth. Take a deep breath in. Inflate your lungs. Hold. Now breathe out on your hand as fast as possible. Your asthma. But you realize you can really inflate your lungs. You can really inflate your lungs, right? Similarly, this time, breathe out. No, tidal volume. Now just you breathe out this time on your hand. Breathe out. The volume that you exhaled out would be called as expiratory reserve volume. The volume that we inhaled in would be called as inspiratory reserve volume. So we have tidal volume. We have I have no idea if this works or not, but maybe this will work. We have the tidal volumes. Is it nothing out? No. Can you see the cursor? Yes, no.
Yes.
This one comes, this one does. Okay. This was the tidal volume. We were breathing. Then we took a deep breath in. How much we inhaled in was the inspiratory reserve volume. Then we did this exercise again, tidal volume, and then we exhaled out to the max. That would be expiratory reserve volume. But you also know the alveoli are lined with a little fluid called as surfactant. The function of the surfactant is to line the alveolar lining. It doesn't allow the alveoli to collapse completely. It allows it to collapse to some extent. The point that I'm trying to make is that even if you exhale out the best that you can, there will be some volume left in your lungs. That's called as residual volume. So we have 4 types of volumes that we can measure in our patient. Inhaled volume, inspiratory reserve volume, expiratory reserve volume, and what is left in the lung is called as residual volume. Of these 4, 3 are very easy to measure. Tidal volume, inspiratory reserve volume, expiratory reserve volume. We just did that. If I gave a little, a manometer, not manometer, a meter, which can measure the volume as you exhale out. We would measure your tidal volume and inspiratory reserve volume and expiratory reserve volume very easily. It is the residual volume that takes a little effort. It's a little bit more complicated. Other three are rather easy to measure. Okay. But we can combine the two volumes, and then that is called as capacity. It's called as capacity. When I say post-vital capacity, you already know I'm talking about combination of two volumes or maybe 2 or 3 volumes. Let us see how. If I combine inspiratory reserve volume, can you see it? And tidal volume, it's called as inspiratory capacity. If I combine inspiratory reserve volume, tidal volume, and expiratory reserve volume, that's called as vital capacity. Folks, vital capacity is a very important measure in pulmonary medicine. And it comprises of inspiratory reserve volume, tidal volume, and expiratory reserve volume. I will go on referring it to as vital capacity or post-vital capacity, FVC. FVC and residual volume, if we put together, that is the total lung capacity. Total lung capacity tells you the entire volume in your patient's lungs. Combination of 4 volumes, IRV, TB, ERV, and RV. Is everybody with me on this? Yes. Vital capacity and total lung capacities are 2 very important measures that we use in making some distinctions between obstructive and restrictive kind of patients. There's another capacity that I want to appreciate that's called as functional residual capacity. Functional residual capacity is a combination of expiratory reserve volume and residual volume. Expiratory reserve volume is ERV plus RV is functional residual capacities. So there are 4 volumes, 4 capacities. 4 volumes, 4 capacities. Of the 4 capacities, post-vital capacity, FVC, and total lung capacities are the 2 important parameters that I would be going back and again, and as we learn how to distinguish these disorders. Okay. I said that volumes of a person, the lung volume of a person, or the variants of that are dependent on the height, the age, and sex. 3 variables will determine what is the actual volume of the patient, or lung volume of the patient. Let's look at the aging and inspect on the lung volumes. As the child is born, they're going in height. They're going in height. Maximum height is achieved somewhere around 18 years of age, right? So as you know, as the child is growing, the lung volumes are increasing. Yes? Yes. So we achieve generally optimum lung volume anywhere between 18 to 20 years of age. Between 20 to 30 is the golden period of life. You're healthy, you're enjoying life and things like that. Generally, no illness, right? So if you're diabetes, enjoy life. That was born 18, 20, maximum lung volume, maximum lung volume, maximum lung volume. Something happens at 30. Something happens at 30. Because what are cells? What is human body made up of? Cells. And cells are undergoing change. Yes. Just you know that. Each cell of your body is replacing itself. In liver, they're replaced. In lungs, they're replaced. Yes? Yes.
Yes.
The very important answer. After 30, the ability to replace the cells starts to go down. It is because of mitochondrial degeneration. That's a normal aging phenomenon. That's a normal aging phenomenon. So what happens, people? After age 30, you start losing function. You start losing? You start losing?
Lung function.
Lung function. And you lose 25 cc per year. Get this in your head. 25 cc per year. That's normal. You can be weightlifting, you can be doing whatever. Healthiest of the healthy. You lose around 25 cc per year, and that will continue. If you're smart enough to smoke and take marijuana and things like that, it's going to be accelerated. Yes, right? So if there's no pollution, nothing, and you're in a healthy environment and you're taking care of yourself, your optimum lung health is between 18 and 30 years of age. After that, the lung function is declining, and it is declining at 25 cc per year. So here it is on the left hand side. As we age, you see the inspiratory reserve volume decreases a little bit. But the fact that I want you to remember, tidal volumes remains the same. Whether you are 70 or you are 20, it remains the same. Same tidal volume that you have achieved will remain the same. ERV decreases. As you can see, if you don't remember, this is the diagram is here to remind you. ERV decreases, RV increases, and then RV increases is something important concept you need to remember. As we age, tidal volume is the same. That is the only volume that remains the same. IRV will decrease, ERV will decrease, it will be compensated by the RV. Okay, RV will take place and your ERV and IRV is decreasing. Your total lung capacity starts to go down a little bit, but your tidal volume remains the same. So we know the effect of aging on the lungs, yes? Focused on, sorry, it's boring. Going back to this, we said that tidal volume is 500 cc, yes?
Yes.
That was a good yes. Everything else is 3 times. IRV 1500 cc, ERV 1500 cc, RV 1500 cc. To put that together, everything is 5 liters. So give and take, all of us are between 4.5 to 5.5, max 6 liters. This basketball guys, maybe they are 7 liters or something like that. That's different. That's different. They are very tall. They're very tall. You understand? I'm talking about the regular height people, anywhere between 5 to 6.5, and 4.5 to 6.5. You are between 4.5 to 5.5 total lung capacity. Is everybody with me on this? Height effects, age effects, and as we will see, because of the hormonal changes, females generally have a little lower lung volume for that age, but that effect is there because of how the body grows and effect. Okay, we need to know these 3 factors. Why? Let me finish. Why? Because if a patient comes to you, you measure their lung volumes. You must know what is expected of that. You understand? We find that out by plugging in patient's age, their height, and the sex. Based on that, we have a normative data of 100 years. If you are 5 feet, 13 years, male sex, what should be your lung volume? We have that data. So when we measure it, we compare it to what it is supposed to be. Please pay attention. We measure it. The computer already tells you based on their height, their age and sex, what is it supposed to be, whether it is 5 liters, 5.2, 5.5, and then you measure it and you calculate the percentage of what it is supposed to be. Is everybody with me on this?
Yeah.
Yes. If you are above 80% of that, you are generally considered healthy. If anything less than that, you have a disease problem. You get that? If you are more than 120% of that, that also is a problem in obstructive lung diseases. What was the question?
I was gonna say. The picture, like in the chart, see IRV, it looks like it's bigger than.
Because I drew it and I'm not very good making it in the slides. And that time ChatGPT wasn't there, I had made it by hand. So I should have made it different, every class this question is asked, so I did give and take, because you got my point there, you understand? Because I made the slide, the PowerPoint wasn't very smart, so I had to draw lines. But you get the point, they're all the same, they may be a little variable, but the concept that we are 5 liters is very easy to remember. TV is 500 cc, everything else is 1500, 1500, 1500, put together total lung capacity of an average healthy person is more or less anything between 20-30 years of age is around 5 liters. Hope you can understand and keep it in your mind. Get that? Okay. So we also learned the 3 variables which affect our patients' ages. We compare it, we measure these volumes and we compare it what is expected of them and we calculate a percentage. If you're above 80% of that, you are normal. If you're below that, you have a disease. Okay. Let's keep going a little further. You and I have already talked about this. There are 3 obstructive lung disorders. A, B, C, asthma, bronchiectasis, and COPD. No need to repeat it. We already, the underlying theme for that is airway resistance. Airway resistance is increased. The diameter of the airway is decreased. We all agree airway disorders patients have difficulty breathing out. They have expiratory wheezing. Why am I going so slow on this class? Because everybody's still not listening. Was there a lecture exam today?
Yeah, and it's us.
Was on. It was exhausting.
Yeah, mental.
What was the exam?
Pharmacology.
Huh?
Pharmacology.
There was pulmonary pharmacology.
No, God, no.
What kind of pharmacology was that?
It was like antipsychotics, diabetes.
Antidepressants,
Antibiotics.
No kidding, huh?
BPH.
Yeah,
Antipsychotics cause weight gain. Did they tell you?
Yes.
yeah,
And SGLT2 drugs cause weight loss. Did they tell you that?
yeah.
See the questions. I'm giving all the questions and the answers. I shouldn't be, right? Anyway, our job is to also learn pharmacology from next lecture onwards. We will put it together. So, yeah. Let's finish this physiology. Okay,
Okay.
so 3 airway disorders and how I want you to think of it. Take your right hand, take your right hand, take your right hand, put it on your neck, put it on your neck, put it on your neck, and squeeze it. That's how an obstructive lung disease patient feels. Your asthma patient is having difficulty in breathing, they are feeling choking. You understand? Simple. When the patient's difficulty in having breathing, they are choking. I just want you to get that feeling. This is not a happy feeling. The airway disorders will be obstructed. And what is a restrictive defect? Restrictive defect? There is a restriction, either lungs cannot expand or the chest wall cannot expand. Either the lungs cannot expand, I mean, they become stiff, fibrosis of the lung, or the chest wall cannot expand. So chest walls become stiff. You want to feel that feeling like you're home today, stand in front of the mirror, take a belt, put it on your chest, and keep tightening it, keep tightening it, keep tightening it, till the time you can't breathe. That's how a restrictive defect patient feels like. Okay? Obstructive defect, restrictive defects. Obstructive defects are airway disorders, ABC. Restrictive defects are the rest of the 4 stations that I talked about. Okay, so those restrictive defects can be divided into intrapulmonary problems like pulmonary fibrosis or extrapulmonary intrathoracic. Extrapulmonary is outside the lung, intrathoracic still within the chest wall chest cavity. That would be the chest wall disorders. So now we have shortness of breath. You might have obstructive lung defect, asthma, bronchiectasis, COPD, or you have a restrictive lung defect. If it's an alveolar restrictive defect, you can diagnose it on a chest X-ray. If it's a pleural restrictive defect, you can diagnose it in a chest X-ray and ultrasound. We do not need PFTs for those 2 things. But if you have pulmonary fibrosis, or I have chest wall disorders, I have a restrictive defect, and I would need pulmonary function test to distinguish. You understand this concept? Yes? Yes.
Yes.
So if you still forget, airway disorders are obstructive. Anything beyond that till the chest wall are all restrictive in nature. Restriction can be either the lungs are fibrosed or the chest wall is not functioning. Lungs are fibrosis, intrapulmonary restriction. Chest wall is not functioning well, is extrapulmonary restriction. And I've talked about this before. Intrapulmonary restriction is fibrosis. Extrapulmonary restriction is chest wall disorders, neuromuscular disorders, diaphragmatic dysfunction, etc., etc. We discussed that when I talked about hypercarpic respiratory failure. Let's get to the nitty-gritty of this. Okay. If I have an obstructive defect, I'm able to take a deep breath in. I cannot exhale out. Did we agree on this?
Yes.
Anything that we agree, you cannot run on that. It is for the class. Okay. So what happens to obstructive lung disease patient, ABC, asthma bronchiectasis, COPD? Getting a deep breath in, it's okay. They're able to expand their chest. Still, when they want to breathe out, they can't. In between, they take another deep breath in. No. Take a deep breath in. Air goes in, that's fine. They cannot breathe out. They can't. They need to breathe. Next breath. More. So they are stacking air in their lungs. Make sense? Yes.
Yes.
So is it okay for me to say that patients who have obstructive lung defect, ultimately their total lung capacity increases? Make sense? Before the total lung capacity increases, their residual volume start to increase. They start to increase. So in obstructive lung defect, as the air is trapped in the lungs, the first thing is the residual volume increases. This is a normal person. If this was the RV, in this patient, total lung capacity is still the same, but the residual volume increases. And if this continues, the more volume in the lung, their total lung capacity increases. So in obstructive lung disease, first RV will increase, then TLC will increase. RV will increase, then TLC will increase. If you measure the lung volumes of your obstructive lung disease patients, mild to moderate will have only elevated RV, very severe will also have elevated TLC. Is everybody with me on this?
Yes.
Do not show up to the exam without understanding this. Okay. What about restriction? Let's talk about restriction. Recap one more time. Restriction is intrathoracic or intrapulmonary or intrathoracic. You understand this concept? Yes?
Yeah.
So I have a restriction. Cannot take a deep breath in. I tried to. The lungs are fibrosed. They won't let me do that. So everything is compressed. Here, slight decrease in the tidal volume, slight decrease in the inspiratory reserve volume, slight decrease in the expiratory reserve volume, slight decrease in the residual volume. The residual volume decreases. Yes?
Yes.
If all these things decrease, obviously, we don't have much of an IQ to say that their total lung capacity is decreased. Yes?
Yes.
So in restrictive lung disorders, RV is decreased, TLC is decreased. In obstructive lung disorders, you're asking a question, ask the stretching, essentially. In restrictive lung disorders, residual volumes decrease and total capacity is decreased. You see how the difference between the two?
Yeah.
Easy? Yes? We use this technique to distinguish obstructive and restrictive lung disorders. Okay. Wonderful. Okay. What did I say? We can measure the tidal volume, inspiratory reserve volume, expiratory reserve volume very easily. How do we do that? Patient sits, it's an outpatient test. There's a little device with basically tube which has a computer chip in it. Patient takes a deep breath in and goes out into that. The way maneuver that we did, we can measure the IRV, we can measure the ERV, and we can measure the TB. So essentially, we can measure the vital capacity. Does that make sense?
Mhm.
So all that we do is you sit down, sitting, device, patient take a deep breath in and exhales out, out, out till the time they can breathe out. So basically you measure the vital capacity of the patient. Okay. We also do one more thing when we do spirometry most of the time. Once this test is done, once this test is completed, the therapist will then give patients a beta agonist, basically to cause bronchodilation, Repeat the maneuver again. You do the test, you get to inhale beta agonist, which causes bronchodilation, repeat the testing. If the measurements increased by 10% of the value, patient has a bronchodilator response. Essentially, we're looking at 10% improvement in the vital capacity or FEV1. We haven't defined FEV1 yet, just hold on. So full spirometry has 3 steps. First, lung volume, beta agonist, repeat the test. Spirometry measures your vital capacity because it's done in a forced way. You ask the patient, breathe out as fast as you can. It's called as forced vital capacity. So vital capacity, forced vital capacity, at least for your level, I will use it interchangeably. Essentially meaning we are measuring the vital capacity. Spirometry measures vital capacity. You can get answer right in the sleep. Yes, good. All right, we did this maneuver just now. We were breathing tidal volume, then took a deep breath in, then we exhaled out to our residual volume. That volume was called as the forced vital capacity. Yes, we're going to do this maneuver one more time. This time we'll pay attention to the timing. So take your right hand, inflate your lungs to the max. We are to a total capacity, right hand, and I want you to breathe out to your residual volume as fast as much. The volume has to be fast and the time has to be high. Most people can do this in 6 seconds. Most people can do this maneuver in 6 seconds, okay? And this is the maneuver that we did just now. We inflated our lungs to the total capacity, and then we exhaled out till the time we couldn't do it. Generally, this takes 6 seconds. Look at the diagram. You realized the flow velocity of the exhaled gas, flow velocity, was very high and then slowly it went down. Yes, it is because in the first second itself, you exhaled 80% of your vital capacity. In first 1 second of this maneuver, you exhaled 80% of your vital capacity. The volume that you exhaled out in the first second of this maneuver is called as FEV1, forced expiratory volume in 1 second. Forced expiratory volume in 1 second, FEV1. Another way, I can say FEV1 is 80% of your vital capacity. People on the back, yes?
Yeah.
Good. People on the left, yes? Right, yes?
Yes.
Democrats, yes? Republicans. But it's good to wake people up. So FEV1 by FVC is 0.80 people. Now think of this way. Imagine this time you're just going to imagine a person cannot breathe out. Remember, they're not going to be able to do 80% of their vital capacity in 1 second. They'll probably do much less. Yes. So the point is, in obstructive lung disease, FEV1 by FVC is less than 0.80. Even if you're asleep today, this is a fact which will never change in medicine. It's a very important concept. In obstructive lung diseases, FEV1 is 80% or higher. If it is less than 80%, you have an obstructive lung defect. FEV1 by FVC less than 0.80 means you have asthma, bronchiectasis, COPD plus asthma, bronchiectasis, or COPD. Is everybody with me on this? Okay. Kind of did this maneuver already, so we're going to skip this. We looked at that. I'm going to put the same diagram in a different way this time, just to make it a little bit easier. This is a time volume curve. Volume is on the y-axis. Time is on the x-axis. Everybody went to high school, yes, x-axis, y-axis, everybody knows that. So patient exhales, just pay attention, patient exhales. This is at their maximum total capacity. They're exhaling out till the time they cannot do anything. What they exhaled out will be the vital capacity, yes. And what they exhaled on the first second will be the FEV1. FEV1 by FVC is 0.80 is higher in healthy people, less than that in people who have obstructive lung disease. I can't keep repeating this again and again. Yes? So let's look at the obstructive lung disease patient. Again, time, volume curve. This is what a healthy person will do. This is what an obstructive person will do, slightly struggling. Their FEV1 is only this much. Vital capacity was still maintained, so FEV1 by FVC ratio is decreased. Yes? People? Okay. Look at the restriction. This time I cannot expand my chest wall. I try to take a deep breath in, exhale out. My vital capacity is much decreased. It is as proportionately to decrease as to FEV1. So the ratio remains the same. So this is the big difference between obstructive and restrictive defect. In obstructive lung defect, FEV1 is 7.80. In restrictive defects, the FEV1 by FVC is still 0.80 is higher. Can we remember this? In obstructive lung disease, RV increases, TLC increases, but the FEV1 FVC ratio decreases. In restrictive lung disease, RVs decrease, TLCs decrease, but the FEV1 FVC ratio is preserved, or is 0.80. That is the big difference between the two disorders. Okay. Blank faces, don't like that. To be very precise, as I said, there is a variation in each one of us. We are all different. To call somebody as obstructive, FEV1 by FVC should be less than 0.70. 0.80 and higher is normal. But to really call somebody obstructive, their FEV1 by FVC ratio should be less than 0.70. Okay. But even that has a problem in terms from statistics point of view. Let's see some of that, the relationships. In obstructive lung disease, the ratio is less than the 5th percentile of FEV1 FVC. All right. Let's just get this out of the way. This is easy. You and I have talked about it in obstructive lung disease. RV is increased, TLC is increased, ratio is decreased. Yes. Then RV is increased, TLC is increased. As time will go, the vital capacity will decrease as well. This is the maneuver. This is normal. In obstructive lung disease, FEV1 is decreased. FVC will ultimately get decreased, but the ratio is decreased. In restrictive lung disease, the lungs are small. The lungs are small as it is shown here. In obstructive lung disease, TLC is increased. This lung is bigger, so that's why it is. And then all the volumes are decreased. TB is decreased, IRV is decreased, RV is decreased, everything is decreased, TLC is decreased. But when we do the maneuver, the FEV1 FVC ratio is preserved. We all good with this? Okay. The ratio is preserved in vital capacity in restrictive lung defect because the flow rates are preserved. We'll come to that in a minute. Okay. Let's just wake up now a little bit. If I was giving this lecture till last year, this would be it. This would be it, just a 0.70, go home and we are fine, but in last 1 year, we have changed. We have changed the definition of obstructive lung defect. I'm sorry for you people, I will change the definition of obstructive lung defect. And I'll explain the reasons for that, why. You and I have already agreed that the lung volumes of a person are dependent on their height, age, and sex. These are 3 parameters. On the basis of that, we measure the volumes, we measure the total lung capacity, RV, and we compare it to the what is expected of them. And if it is less than 0.80, obviously there is an abnormal. Okay. Since there is so much variation in all of us, 0.70 cutoff has a problem. It may sometimes give a little variation. Some people may still be normal and have FEV1, FVC less than 0.80. Yeah, break up. 0.80, and some people who have restrictive with completely lower values may still have normal lung volumes. Reason for that is because you and I talked about as we age, the lung volumes are going down. So we hide behind something called as standard normal distribution. Difficult concept, just work with me. Difficult concept, just work with me. If you take any data point in medicine, whether it's creatinine, it is hemoglobin, it is hemoglobin A1C, etc., a normal distribution will mean that some people are on the higher side, some people are on the lower side. There is not one specific point. You understand? Just everybody doesn't have hemoglobin of 14.5. No, some people are 13.5, some 14.8, things like that. So there is a variation in all of us. And let's be a little bit more scientific now and decide how we look at the data when there is a little dispersion of the normative data. If you haven't done statistics, please follow me. If you look at thousands of people who have absolutely no shortness of breath, their chest X-rays are completely normal. If you plot their volume, any volume, vital capacity, FEV1, RV, TLC, does not matter. Any volume, any data set that you want. Some will be a little higher, some will be lower. I've been saying this for a while. Yes. Yes. And folks, initially I said total lung capacity 4.4 to 5.5. Did I say that? Yes. It is because the distribution of total lung capacity is a bell-shaped curve. It's a bell-shaped curve. In between your mean, some people are a little higher than the mean, some people are below the mean. Yes. Same for FEV1, same for FVC, same for everything else. So if I just took off 1.70 as a cutoff value, some people who are healthy may look abnormal. So 0.70 value slowly is going to get faded away. Then how are we going to make the distinction? We hide behind standard deviation and means, something called a Z-score. Z-scores are not going away. Z-scores are going to be more and more used in medicine. So even if you don't want to listen to me, please pay attention. Look at this graph. Look at this graph. Nowhere in YouTube is this explained like this. I'm telling you, you'll get confused. No, in this graph, this is the midpoint. Yes.
Yes.
This is the mean. Everybody agrees with that? Yes.
Yes.
Okay. And then you can plot how far is the standard deviation. How far is the standard deviation from the mean? How far is the standard deviation of this data from the mean? In a perfectly normal distribution like this, mean minus 1 standard deviation would be 0. I'll explain that in a minute. So we can, if my patient is, this is the mean, and if I'm here, no. Can you see this? If this is the mean, and if I'm here, yes. Another patient may be here, yes. Another patient may be here, another patient may be here. More or less, they all normal, yes. But if I am 1.65 times, don't write, it's there. 1.65 times away from the mean. One more time. 1.65 standard deviation away from the mean, I am abnormal. One more time. If my data, and it's on the diagram now, let's pay attention to it. And I'm getting visual cues from you people. If I am within one standard deviation, I'm okay. I'm at 1.65 deviation from the mean, my reading, and less than that, I am abnormal. Yes, this is arbitrarily defined for every data in pulmonary medicine now, okay? This is called as Z-score. What is Z-score? Z-score is representation of the data in terms of how far you are away from the mean in terms of standard deviation. You understand? If my mean is 50, okay, and 1.65 standard deviation or lower is 25, okay? If I'm 26, I'm still normal. But if I'm 24, I'm abnormal. Yes? So for now onwards, today we're learning a new term. Anything below 1.65 standard deviation from the mean in PFTs would be abnormal. And that's the first Z-score value. It is here. That value is here, okay? And that value will be called as lower limit of normal. What will be called as? LLN. I will please say me. Lower limit of normal. Lower limit of normal, which is 1.65 times standard deviation, is the 5th percentile of the data. Means 5% of the population that you would study would be below this, and they would be considered abnormal. So in obstructive lung disease, going forward today, FEV1 by FVC, if it is less than the lower limit of normal, you are abnormal. The new machines and the new printouts, they may not give FEV1, FVC value as much as they will give you the lower limit of normal. So you have to see whether it is below the lower limit of normal or not. That's why I wanted to do this lecture personally. You cannot explain that on Zoom call. So predicted PFTs going forward today, we're going to look at TLC less than the lower limit of normal, RV less than the lower limit of normal, FEV1, FVC less than the lower limit of normal. What is lower limit of normal? It is the last fifth. You are below the 5th percentile of the healthy population of your age. You understand? Computer tells you this person, this height, this age, this sex, this should be the total lung capacity. They already have the lower limit of normal for that population. If it is below that, you are abnormal. You get this concept? So Z-scores, how far you're away from the standard deviation, more than 1.65. Below that, you are abnormal. That corresponds to the 5th percentile of the standard deviation. Okay. Why do we do that? Just to give you an idea. This is what I wanted to talk about. So just pay attention for a minute, 1 second. On my y-axis are the age of the healthy population from 20 to 80. We agreed at 20, the lung volumes are the best. Yes. If we arbitrarily agree, everybody who comes to me to see for shortness of breath, if they are below 70, they are abnormal. If I do that, which is what we were doing before. But I also told you that just I showed you the residual volume increases in aging. As I did not show you that? Yes. Didn't I contradict myself? Let me go back to wake people up. Didn't I contradict myself when I say in aging, RV increases? Yes. And then I told you in obstructive lung disease, RV increases. You see that? Yes. So it's possible. It's possible. I'm within the normal limit, but my RV looks higher and I would have been called as abnormal. Yes. So for that reason, we just don't take absolute values nowadays. We look at the Z-scores. And if I take a population, the FEV1 by FVC in healthy population, if I just do 0.70, some patients who have the disease would be missed. So there'll be false negatives. On the other hand, a big number of old people, the FE1, FEC also goes down. It's not 0.70, it's 0.65 at 8 years is still normal. So they would have been called as deceased patients. You understand? Because of the change in the RV and decrease in the FE1, FEC ratio normative data on healthy population, we need to look at lower limits of normal, not 0.70. So today, now onwards, the definition of obstructive lung disease is FE1 by FEC less than the lower limit of normal, not 0.70. Is that correct? Is that everybody good with this? We can further divide into severity depending on what the values of the Z-scores are. Anywhere between 0.165 to 2.5 is mild, 2.5 to 4 is moderate, and then severe. Depending upon this, you can tell how severe a patient's disease is. Okay. I talked about spirometry. We talked about that it can measure your FE1, FEC. It can measure the ERV and IRV. It cannot measure residual volume. If I need to measure residual volume, you need to come to the lab to sit in a machine like this. It is called as body plethysmography. Not important for me to go into the principle of this. You sit inside the chamber. Based on some maneuvers, we can measure the residual volume. If I can measure the residual volume, people, I can calculate your total lung capacity. Yes, TLC measurement requires, the calculation requires measurement of residual volume. Residual volume is not measured on a simple little device, handheld device. That's a big thing like this in which the patient sit and we apply some principles to measure the residual volume, and then we add it to the rest of the ERV, IRV, and TV, and we get the total lung capacity. I've been saying loud and clear, TLC is increased in obstructive, it is decreased in the restrictive lung diseases. Everybody good with this? All right, a few more things about spirometry. I showed you about the time volume curve, which is the time on this side and the volume, and how we can look at the FEC and FEV1. Generally, we nowadays look at a flow volume curve. Flow is on the y-axis, volume is now on the x-axis. The flow volume curve is from here. You take a deep breath in and exhale out. Take a deep breath in and exhale out is plotted like this. This is your inspiration, this is your exhalation, and you get a plot like this. A normal flow volume curve is a clown hat appearance, Touch your imagination, it does look like a clown hat. Does it not? Yes. Okay. So how does it help? We can look at the flow volume curve, and based on its determinations, its parameters and its shape, we can find out if patient is obstructive or restrictive. How easy is that? This is a patient with asthma. This is how a normal flow volume curve should be. By definition, inspiration is negative. So this is inspiration, exhalation is positive. Okay. If I have obstructive lung disease, my inspiration is like this, but exhalation starts to become curvilinear. It's become a little concave. Everybody sees that? Yes. Instead of straight line, now it becomes a little curvilinear. Yes? Yes. So looking at the flow volume loop and the concavity of the expiratory limb also tells you an idea that this is an expiratory, that patient has an obstructive lung defect. I am not giving flow volume curves on the exam, so please don't fret on that, but you should know this. In asthma, for example, if a patient has asthma, if they have disease, it will look like that. I give them medicine, it will revert back to normal. So asthma is a reversible process. We learned that in my first lecture. Asthma is a reversible process. On the other hand, COPD patients, once they have the disease process, see the concavity here? Yes, see that? Even if you treat them, they never recover. This is one big difference between asthma and COPD. Asthma is a reversible disease. COPD is not a reversible process. To recap everything, obstructive lung disease, initially it will look like this. As the disease progresses, there's a mild concavity, then severe concavity in obstructive lung disease. In asthma, you give them medicine, this will revert back to normal. In asthma, you give medicine, this will become this. In COPD and bronchiectasis, it will look like that. You understand? On the other hand, restrictive lung diseases, the whole thing is pressed horizontally. What do I mean by that? This is a normal looking flow volume loop. As disease progresses, it become compressed, then become more compressed. So flow volume loops do give us an advantage by looking at just the picture as to what kind of disease my patient has. It is complementary to the volume measurements that we do. So we look at the volumes, look at the lower limit of normals, and we look at the flow volumes. Both should agree with each other. Is everybody good with this? There's one more thing that we measure, something called as diffusing capacity. Diffusing capacity tells you how good the air, the oxygen in the air is able to pass into the RBCs in the blood. Remember, if I have fibrosis, oxygen will have a hard time going through. Yes. So this is called as diffusing capacity of carbon monoxide. We measure it by this effect is measured by giving the patient a little bit of carbon monoxide. Why do we do that? Carbon monoxide is 200 times more diffusible than oxygen, okay? So we give the patient air with a little bit admixture of carbon monoxide. You know that in air there is no carbon monoxide, yes? But in the lab, we can give the patient a little things in which this air mixed with a little carbon monoxide, okay? The patient takes a deep breath in, air goes into the lung, and when they exhale out, we collect that air. The difference between what we gave to the patient and what came out stayed inside the blood, yes? And bigger the difference, more efficient the gas exchange. Does that make sense? Hello?
Yes, yeah.
Just for my sake, say yes.
Yes.
No. Carbon monoxide is very good at passing through the lungs into the blood vessel. So you give the patient a little 0.001% of carbon monoxide mixed with air. They inhale it and hold their breath and exhale out. We collect the gas, exhale gas. So we can measure the carbon monoxide concentration in the inhaled gas and the exhale gas. Yes. The difference between the two is what went inside the lungs. Yes. Based on the calculation, we can calculate what is called as diffusing capacity of carbon monoxide. It tells you alveolar capillary junction function, how good the lungs are in transporting gas from the alveoli into the blood vessels. So PFT folks, three things we measure. We measure volumes. We look at RV, we look at TLC, we measure FE1 by FEC. We look at the flow volume curve, yes, and we look at the diffusing capacities. This is the whole gamut of TFT. So why am I talking all about it? Let's recap this together into a summary slide so that we know what is coming in the exam. Okay. Obstructive lung disease, FE1 by FEC is less than 0.70 or lower limit of normal. Restrictive lung disease, RV is decreased, TLC is decreased, but the ratio is preserved. In mixed defects, both may be present, but I'm not asking you mixed defects. So obstructives are asthma bronchiectasis, COPD. Restrictive are pulmonary fibrosis and the chest wall disorders. And if you've been sleeping, wake up now in obstructive and restrictive. You have to go through all this to go through this. What happens to vital capacity? In obstructive lung disease, vital capacity may be normal initially, then decreases. In restrictive, it is always decreased. FEV1 is decreased in obstruction, it is decreased in restriction proportionately. But the ratio FEV1 by FEC is less than the lower limit of normal in obstruction. It is above the lower limit of normal in restriction. What happens to TLC? It increases in obstruction, it decreases in restriction. What happens to RV? It increases in obstruction, it decreases in restriction. What happens to diffusing capacity of carbon monoxide? It decreases in obstruction, it decreases in restriction. This is a recap. We look at these PFTs. We are able to make a distinction whether my patient has an airway problem or a fibrosis or a chest wall problem based on this and your physical examination. Each disease process has 4 dimensions. Get this right. What the patient tells you, that's subjective. What is your clinical examination? I went through this in detail in my first lecture. Expiratory wheezing, crackles, this, that. Third, what does your chest X-ray tells you? It will be helpful in alveolar and pleural disorders. It may not be helpful in airway and interstitial lung disease. That's where the PFTs will be helpful. If you're still not sure about these things, fourth dimension of the disease, patient is following the patient. Sometimes it's not very clear. Early disease is not very clear, but if you follow the patient, things will become very clear as to which direction the patient is going. Let's look at it in a more clear form. If I have a shortness of breath, and I have a clear chest X-ray, I'll come to you, you will do a spirometry. If I have spirometry, the ratio is less than 0.70, and I just added it now, or FeV1, FVC is less than the lower limit of normal, I have obstructive lung disease. Which kind? I will give the bronchodilator. We talked about the bronchodilator challenge. I give the bronchodilator the response. If it increases, if my FeV1 increases by 10%, I have asthma. If it doesn't, I have COPD or bronchiectasis. How would I make the distinction? I will do a CAT scan of the chest. Fair enough? Other side, I have shortness of breath, normal chest X-ray, I do a spirometry. My FeV1 by FVC is more than the 0.70 or more than the lower limit of normal. Okay, I look at the vital capacity. Even if the ratio is normal, if the vital capacity is low than the lower limit of normal, I do have a potential restrictive lung defect. I measure the diffusing capacity. If diffusing capacity is very, very decreased, I have intrathoracic restrictive defects. If the diffusing capacity is normal, where's the cuts? Is normal, I generally have an extra pulmonary restrictive defect. Third variable, please wake up now. I told you in my first lecture that in asthma, particularly in asthma, which is episodic in nature, means patient has shortness of breath, normal, shortness of breath, normal. If they are normal, at that time, if you do spirometry, it will come out normal. That's a very common presentation, by the way. Patient comes to you, I feel it's chest tightening, I feel shortness of breath, I feel wheezing off and on. But today I'm not having that, but that's why I found time to come and see you. How do we pick that up? How do we pick up those patients whose spirometry is normal but have a history suggestive of asthma? We will recreate asthma-like features in the lab. How do we do that? Here it is, shortness of breath, normal chest X-ray, spirometry, FeV1, FVC is more than 0.70, means it's normal. But patient has history very suggestive of asthma. Okay, I give them in the lab methacholine. They are made to inhale methacholine. Methacholine is a bronchoconstrictor. Methacholine is a bronchoconstrictor. And we measure the FeV1 again. And if the FeV1 decreases by 20%, this is not 10% here, this is 20%. People make mistake all the time. If on methacholine challenge test in a person who has normal PFT, if the FeV1 goes down by 20%, my patient has bronchial asthma. Is that clear to everyone? This is the algorithm that every pulmonologist follows day in and day out 100 times a day. And we have gone through it step by step as to why is and what. And make sure you're aware of this. What's the time?
It's 5:18. That's all.
5:30. Let's take a break. We finished our spirometry and PFT setup. Let me move to the next section, but I want to take it.
Yeah, but batteries. No, they're sitting until 8. Huh?
Well, you're not enjoying the lecture? It's boring.
To my baby.
Work with me, we finish faster, okay?
Yeah.
So the gas tin one.
Oh, I have. I need some also built, so it's.
I wrote-
I was like, wow. Yeah.
Gas has to be more difficult for me.
I'm doing mine. What are you trying to do? I'm doing mine right now. That was like.
I got to.
Yes. Nice little cross. I know, I thought. I was like, oh, it's so. So good. Change it out. I know, I'm not sorry, batteries. This is looking at my red. Are you just like going with this every single time? Looking at it now, like he's saying is. Yeah, and be like. Oh, wow.
Tomorrow's class is where? Where is tomorrow's class? Tomorrow's class is where?
It's on Zoom tomorrow.
On Zoom?
Yeah,
And-
Wednesday's the first day.
Yeah.
And Thursday's the movie.
Then it's Monday and Tuesday or Tuesday?
We did not get it. Wednesday is July first already. We did not get July schedule yet.
We are one lecture behind.
Oh, shit, you're right.
Last Thursday. And I got confused. I kept on logging in and I think you guys were not in.
Yeah, they didn't put us on the schedule on Thursday.
There was some confusion.
Yeah.
No worries.
Yeah, today we gonna get. You can use it as a parent. Yeah. I usually have the rest all the time. And I find that their music is just such good, like, music was both, like, I was like, it was my mom's birthday, and I was like, I usually dance on my phone, like, that's what she likes, and then recently, I was like, she's like, but, yeah. Yeah. I saw. Yeah. Agree. I like really distracted. Yeah, I need to go fill in for a lot of, and then, yeah, that was. Yeah. And then. No, that's good, okay.
I'll have chat and just like. Clinical medicine, yeah. So, things like that, you want to take days, you're like, fine.
Yeah.
Right, so. I'm like, I'll get out. Yeah. And like. Something this has to go. Yeah.
Yeah, but you know, no, we're not.
See what I get? I got to see what I
Yeah, it's how it's said.
True, sure, like that.
Yes, I like.
Oh, you're sorry.
Yeah.
And then like that.
You know, okay, not, I think for high.
I try to do. On the weekend. I think
Yeah.
It's gonna get people inside, get everybody inside,
Oh, that's good. Rally first.
keep moving.
Yeah, so I think.
Right.
Yeah, but part of it. Trying to call me, don't discuss this. No, I can't do that. I know that too. Yeah. I can do like one and.
I tried writing as many people as possible. I think everybody's outside. Want some?
Good, I had lunch dinner, but.
That's spinach. All right.
Those are cool lunch combos.
Yeah.
You see if you can round up people, are they all lost?
Yeah, I closed as many people as possible. We're restarting, guys.
They are lining up with the. So many people I lost. They're probably in the right way.
Like the parking lot, like just.
No, I think that they're.
Yeah, I saw that before. We're gonna be closing this.
I got like two people.
There we go.
Okay.
Good.
Two people, man.
Are we okay with the material up till now, or it is too much?
It's good so far.
It's good.
Backbenchers? They don't wanna play with me.
Go.
No,
You okay, not okay?
It's been worse. Well, it's been worse. We had MMD at this time. This is not that bad.
It should be. I know, I share that feeling, trust me, my day is not over
We
yet,
stayed like.
and after I'm done, it's still not over after that.
Still, he was just left.
Okay. Let's keep moving because the first four lectures are basically meant to kind of review everything in pulmonology. We also, in the same way, we're kind of going back to each disease process and putting things together. So when we talk about the diseases per se, all these concepts will be repeated again. So it will make more and more sense. You know, it's a physiology heavy first four lectures. But I feel if it goes smoothly and you guys get a good grounding on this, understanding diseases and their management would be rather easy.
Wait, I have a quick question. Is your first test the first 5 lectures, 6 lectures?
My
Wait, you only
lecture,
have one test?
yes.
How many lectures do you have total?
10 or 11.
10 or 11. For one test?
I've been doing it for 20 years. Nobody has failed. If you guys fail, then it's
Oh,
your.
nobody's failed?
Ever? Oh, okay. That's pretty motivating. Do you give like 100 questions, something like that? Okay, that's fine.
But the same point, just focus on the lectures that I'm giving. Try not to read from the book or something like that, then it gets confusing. The thing that I'm giving is absolutely current, okay?
Mm.
And it is more than what you require. I know that. Even if you were half awake, even 5% awake, you will pass. Okay, let's keep moving. We looked at the spirometry and how is it helpful in distinguishing between restrictive and obstructive lung disorders. There are a few other signs and symptoms that we must look at in our patients. Before I go any further, I just need to bring you to your point that in the end, what we're talking about is the relationship between the ventilation, air comes in and air goes out, that's the ventilation, and the perfusion, which is the blood flow through the lungs. And each alveoli has its own blood vessel along with it, and the ventilation perfusion ratio remains the same. In the full lung wall, if you take the entire lung, the ventilation perfusion ratio should be 0.8. How interesting is that? Everything is here is 0.8. The perfusion to ventilation ratio is generally 0.8. But that's not exactly true for each and every cell. This is how I want you to look at it. If I look at the lungs, bottom to top. Now, no, lung is not a cylinder. It's actually a pyramid. It's actually a pyramid. The bottom, more lung volume. As I go up, less lung volume, okay? It's not a cylinder, it's a pyramid. There is more alveoli at the base, there is less at the apex, yes?
Mhm.
The blood flow to the lungs is gravity dependent. Gravity dependent. Increase. But last time, get into your head, the blood flow, easy for my heart to push blood to the lower lung, then to the apex. Yes?
Yes.
You see that?
Mhm.
So there is more blood flow to the lower lung. There is less blood flow to the apex. That's an absolutely true statement. And entire pulmonary is actually dependent on that to explain. Same thing. If I look at the perfusion, this is the base and this is the apex. This is the base of the lung, people. And this is the apex, which is the top of the lung. And I draw a line. The blood volume, the blood flow is higher at the base and it decreases as I go to the apex. Make sense? That's a gravity effect. Yes? Okay. Essentially, if I look at the ventilation, you and I just agreed there is more alveoli at the base and there's very little at the apex. Yes. So again, ventilation is more at the base. As I go up, it decreases. It decreases, but it doesn't decrease as much as the perfusion. One more time, the ventilation and perfusion are more at the base and they decrease as we go up. But perfusion decreases much more as compared to the ventilation. Does that make sense?
Yes.
Yes.
So ventilation, perfusion ratios, ventilation and perfusion ratios are variable. There is much more decreased perfusion as compared to ventilation at the apex of the lung. But at the base of the lung, perfusion is much more than the ventilation. So ventilation perfusion ratio is a little higher. Okay. As I go along, the ventilation going from base to the apex, the ventilation perfusion ratio, which is the dotted line, keeps on increasing. One more time. Students confuse this all the time. At the base, there is more ventilation, more apex. Yes. At the top, there is less ventilation, less perfusion. Yes. But perfusion is much less as compared to ventilation. You understand? Relatively, there's much less perfusion. So ventilation perfusion ratio is more than 1 at the apex, and it is less than 1 at the base. But look at this, where they cross each other, stop writing. That ratio is 0.8, somewhere around here. So it should be a little lower. So if I take the entire lung, the normal ventilation perfusion ratio is 0.8. Yes, this is for the entire lung. The entire lung has millions of alveoli. Yes, but if I look at the alveoli at the base, there is more perfusion as compared to ventilation. Why do I say that? At the base, there is more perfusion relative to ventilation. Yes. So that. Why is there a confusion? This is the perfusion. This is going down as I move to the apex. Yes. This is the ventilation. It is also going down as I move to the apex, but it does not decrease as much as the perfusion. Yes. So there is relatively more air at the apex as compared to perfusion. There is relatively less air at the base as compared to the perfusion. Does that make sense? So why is this important? Diseases that we inhale are more common at the apex of the lung. Influenza, tuberculosis, silicosis, asbestosis, all that stuff. They all start at the apex. Apex alveoli are more affected as compared to the base. Diseases that come to us by blood flow. I have infection in my kidney. I get seeded bloodstream infection, more abscess formation, more in the lower lobes. Yes? Yes. That's the critical lobes. The same reason for the last time, and we'll revisit again. Primary lung cancer, which is secondary to COPD. COPD is an upper lobe disorder. If you smoke cigarette, upper lobe. Yes?
Yes.
Lung cancer, primary lung cancer is an upper lobe disorder. Metastatic cancer, if I have colon cancer, kidney cancer, there's that. And then I seed my lungs, where it is going to go? Lower lobes. Yes, metastatic lung disease is more pronounced in the lower lobes. Primary lung cancer is more pronounced in the upper lobe. Now you know the reasons for all this. Easy to remember. Yes.
Yeah.
Diseases that we inhale, upper lobe. Diseases that come to us from blood flow, from other organs, they will be more common in the lower lobes. Let's move on to cough. This should be the easiest one. We talked about cough in context of airway alveolar interstitial disorders. In some it was wet, in some it was with sputum, some with hemoptysis. Then it was dry cough in interstitial lung disease. And asthma, again, it was dry, not a little bit of mucus, but no sputum. Yes, a cough characteristic is very different with each lung disorders. So let's look at cough in a little bit more close way for those whenever this is becomes a bigger problem. Patient presents you just with cough. Now, cough can be acute, subacute, and chronic. Anything less than 8 weeks is less than 3 weeks is acute, 3 to 8 weeks is subacute, and more than 8 weeks is chronic. A lot of patients come to their physicians with chronic cough. It's a very common outpatient presentation. Okay. So what causes acute cough? Acute cough is generally exacerbation of your underlying cardiopulmonary disorder. You have CHF, you have interstitial lung disease, you have COPD, suddenly becomes worse, so you come to that. That's generally acute kind of cough. And what about subacute cough? Subacute cough, which lasts between 3 and 8 weeks, generally from Bordetella pertussis. Pertussis is an infection for which we all get the vaccination, you know, DPT. Pertussis causes subacute cough. If pertussis occurs, it's a violent cough which lasts 8 weeks. Slowly bruise, and then patient cough their brains out. Sometimes they vomit with a cough, and it lasts for around 8 weeks. I talk about it because there's been a resurgence of pertussis, at least in New York State, and we see that once in a while. Let's tackle the chronic cough. Now, chronic cough, acute cough, you look for patients, take a deep history of underlying cardiopulmonary disorders and try to see if you can fix it. Wait. Most acute cough, if the patient is underlying healthy, will go away with or without antibiotics. Generally, it is a viral infection. In healthy people, it's a viral infection. In patients with chronic lung disease, it tells you it's an exacerbation of underlying disorder. Subacute cough, which lasts between 3 to 8 months, 8 weeks with violent cough with eosinophilia is Bordetella pertussis. It is chronic cough. I never want you to do nothing about it. Always take it seriously. If patient comes to you and say, I have cough for more than 2 months, 8 weeks, you need to investigate. You need to investigate. And the investigation of choice would be, you must take a detailed history, physical exam, etc., etc. You must do a chest X-ray. You must do a chest X-ray. I didn't say that for acute cough. I didn't say that for subacute cough, but for chronic cough, you will start with a chest X-ray. Because if chest X-ray shows abnormalities, those are probably responsible for this chronic cough, and then they need to be addressed: congestive heart failure, pneumonia, cancer, what have you. Problem occurs, patient comes to you with chronic cough. Do the X-ray is normal? Now what do I do? That's a big problem. Chronic cough, normal chest X-ray. What do I do? Here are the choices. Chronic cough, when this chest X-ray is normal and patient is not a smoker. Chronic cough, chest X-ray is normal, patient is not a smoker, occurs from 4 causes. Underlying asthma, which has not been appreciated, post-nasal drip, which is also called as upper airway cough syndrome, eosinophilic bronchitis, and gastroesophageal reflux disease. A cough which has lasted more than 8 weeks. There are 4 causes if chest X-ray is normal. They are asthma, postnasal drip, gastroesophageal reflux disease, and a rare condition called as eosinophilic bronchitis. Some patients may also have medication-related cough. For your level, medication-related cough from 2 causes: heavy doses of beta blockers and high doses of angiotensin converting enzyme inhibitors. 2 drugs which can cause very disturbing cough to the patient to the point that they seek help are ACE inhibitors and beta blockers. So chronic cough, normal chest X-ray, history of smoking. If you're smoking, stop smoking. And also take history of medication intakes. 2 medications that we are concerned about are beta blockers and ACE inhibitors. Both are cardiology related. Maybe suggest to the patient they need to talk to a cardiologist to decrease this dose or use alternative medications. Then we will look at these 4 causes: asthma, reflux, postnasal drip, and eosinophilic bronchitis. What is eosinophilic bronchitis? Okay. We talked about the PFTs, yes? So we also measured something called as peak expiratory flow. Peak expiratory flow. What is peak expiratory flow? Let me go back one more time. I don't know how to find this. I showed you the normal. Okay. This is the flow volume loop. This is the inhalation, and this is the clown hat appearance. Yes.
Yes.
The tip of this is peak expiratory flow, PEF. Yes. In obstructive lung disease, this goes down. In restrictive, it remains the same. I showed you that. In obstructive lung disease, it goes down. In restrictive lung disease, it stays the same for a very long period of time. Okay. That is the peak expiratory flow. Why is it not moving? God only knows. So a peak expiratory flow has a variation. Actually, if you get up in the morning and you measure your peak expiratory flow, it is higher. At this point, 6 o'clock, it is the lowest. Yes, what's the question? Again, I haven't talked about sitagliptin yet. Yeah, it's there on the slide. Okay. Don't change anything. Sitagliptin is there. Of course, it causes chronic cough. So just say that. Where was I? Peak expiratory flow. Peak expiratory flow is highest at 6 a.m. and it is lowest at 6 p.m. Those of who have asthma or have relatives who have asthma, children who have asthma, they tell you make the peak expiratory flow rate first thing in the morning when you get up. It is because our cortisol is highest at 6 a.m. Yes, 6 a.m. cortisol is highest, and high cortisol, high steroid levels open your lungs a little bit. That's why your peak expiratory flow is highest at 6 a.m. Cortisol level lowest 6 p.m. They can go lower after a stress full exam, by the way. So maybe you have lower stress today, lower cortisol levels. But in normal patients, there is a slight variation. All of us, if you are healthy, there's a slight variation in peak expiratory flow. But in asthma patients, in asthmatic patients, this variability is more than 20%. Morning and evening variability is more than 20%, okay? In patients who have eosinophilic bronchitis, when I do spirometry and do the bronchodilator challenge, that is negative. That is negative. The methacholine challenge tests are negative. So what is eosinophilic bronchitis? Eosinophilic bronchitis is a condition in which eosinophils are invading the airways. Eosinophils are invading the
Airways.
eosinophils are not going to leave you people. And asthma is from eosinophilic infiltration in the airways. So in this condition, very similar to asthma, in which the airways are infiltrated with eosinophils. If you take the sputum sample, they have high eosinophil level as well. But their methacholine challenge tests are negative. Remember the methacholine challenge test, normal spirometry, you think asthma, you give them methacholine and look for a fever decrease, it decreases by 20%. It is methacholine challenge test positive. Yes.
Yes.
In patients with eosinophilic bronchitis, methacholine challenge test is negative. Otherwise, they behave very much like bronchial asthma patients. If you take a sputum sample, this sputum is full of eosinophils. Treatment of this condition is inhaled steroids.
Yes,
One for the last time. You remember for perpetuity. Steroids kill eosinophils. Remember this? Steroids. Say that. Kill eosinophils. Absolutely true statement. And that is why we use high doses of steroids in asthma. That is why we use high doses of steroids, not high dose.
Oh.
We use steroids more effectively in asthma. And that's why we will learn that in COPD, we don't want to use steroids. It's not an eosinophilic disorder. That's one distinction between asthma and COPD. Okay, so a condition, eosinophilic bronchitis is the condition in patient has history of wheezing, he has sputum in the blood, sputum in the sputum, but their methacholine challenge tests are negative. Yes, this condition is also treated with inhaled steroids because inhaled steroids will kill the eosinophils in the airway. Okay, very much similar. Yes. Okay. So with these little concepts in mind, let's tackle the algorithm. Chronic cough, chest X-ray is negative. Chronic cough, chest X-ray is negative. Chest X-ray shows pleural effusion, mass, pneumonia, fibrosis. You treat that. Yes. But if chest X-ray is clear, patient's been having cough for 2 weeks, that is a sinister sign. We cannot ignore. How many people get sued for this thing? You have no idea. So I want to wake you people up on this. If you do primary care, urgent care, all that garbage that people do, that in the sense that they don't look at the patient and they're looking at the computer all the time, you will get in trouble. Chronic cough is a slippery slope. And how many times I see things missed, you have no idea. Okay, chronic cough, chest X-ray is normal. Okay, you are going to ask for a history of smoking. You are now going to ask for history of medication intake. Okay, let's get a little more sophisticated. Yes, ACE inhibitors, beta blockers, and a diabetic medicine called sitagliptin, which also irritates the lung. Okay, so chronic cough can be a drug-induced thing. We must know this. Okay. If chest X-ray was normal, suggestion to the patient to see if these medicines can be changed. Yes. If he is able to do that and still cough persists, he comes back to you. Then there are a few red flare signs, which are risk factors. Chronic cough with weight loss. Chronic cough with weight loss is a very big sign that there is a malignancy somewhere. If patient having weight loss, big problem. Okay. And if that's not the case, yes,
Sorry, is this intentional weight loss or is this unintentional weight loss?
unintentional weight loss.
Unintentional, okay.
I don't know if intentional weight loss people have cough.
That's, I just wanted to know.
Let me put it this way. If you have 10% weight loss in 6 months, that's troublesome. If it's not intentional, it's troublesome. 9 out of 10 times it will be a malignancy. Okay. So chronic cough, normal chest X-ray, red signs, patients having infections, high ESR, inflammatory markers are high, and all this kind of things. So means some underlying problems going on. But if patients looks otherwise workup is negative, look for medications. 3 we talked about. Try to convince patient to quit smoking, and then tackle these 4 disorders. How are we going to do that? Patients for post-nasal drip, nasal steroids. Post-nasal drip, nasal steroids. Okay. For asthma, inhaled steroids. For eosinophilic bronchitis, inhaled steroids. For reflux, proton pump inhibitors. Okay. Here is what we need to know. Most patients have more than one problem. Most patients have more than one problem. So we treat all 4 same time. You give nasal steroids, you give inhaled steroids, and you give proton pump inhibitors. 3 medicines will cover 4 diseases. Does that make sense? Already patients suffering for 4 weeks. We give nasal steroids, we give inhaled steroids for asthma and eosinophilic bronchitis, and we give proton pump inhibitors for 6 to 8 weeks. 95 or higher percentage of patients should have significant relief at 6-week interval if they follow this regimen. And those who don't, they need bronchoscopy, esophagoscopy, CAT scans, and further workup. One more time. Chronic cough. If patient is a chronic underlying disorder, that should be addressed. Their chest X-rays will be abnormal, pleural effusions, lung cancer, pneumonia, fibrosis, whatever it is. If chest X-ray is normal, history of medication use, history of smoking, that should be tackled and counseled. Medications should be changed and smoking should be stopped. But if patient still very troublesome cough, and has no weight loss and those kind of things, we will give nasal steroids, give you inhaled steroids, we will give proton pump inhibitors. Ask the patient to come back to you in 6 weeks' time. 95% of your patients should have a complete relief. And those 5% patients who do not have a relief, they should be sent back to the pulmonologist and things like that, because they need CAT scans of the sinuses, CAT scan of the chest, they need a bronchoscopy, they need an endoscopy, and further workup, because they definitely have some other more sinister diagnosis that needs to be looked into. So chronic cough, we will not pass off. We will never ignore it, a chronic cough in our patients. And these are the red signs. If patient has chronic cough, hemoptysis, smoker, hoarseness, fever, vomiting, etc., means patient has significant things going on. And what further investigations if those 5% patients who come back after you have given nasal steroids, inhaled steroids, and proton pump inhibitors, and they're still coming back to you, they need 24-hour esophageal monitoring, sinus imaging, high resolution CAT scan, bronchoscopy, cardiac work. Leave that to the specialist to work on. So chronic cough has an algorithm that you need to follow very closely. Okay. Let's keep moving. What are the other abnormal signs that patients can present with in patients who have pulmonary disorders? Let's look at the apneas. Okay. What is an apnea? Apnea is cessation of breathing. Apnea is cessation of breathing. Okay. The definition of apnea is different in children as compared to adults, please. Let's start from the kids first. Apnea in infants is age dependent. Regular definition is cessation of breathing more than 20 seconds. Cessation of breathing more than 20 seconds. By the way, in adults, the definition is cessation of breathing for more than 10 seconds. 20 seconds in infants, 10 seconds in adults, okay? They may have a tachypnea as well, ignore tachypnea for now. When the child is born, if they're born premature, if they're born premature, they may have apneas. They may have apneas, okay? Most of these apneas recover by the age of 40 weeks, okay? That apnea which occurs in prematurity is called as apnea of prematurity. Usually, as the child crosses, if it's born at 34 weeks, you observe by 40 weeks, the respiratory center has completely developed. Most of these children outgrow it. Most of these children outgrow it because the brain's respiratory center has gotten better. Okay. In some, at the age of 40, they still have apneas, and that is a very cause of concern. That is a very cause of concern. And this is how it presents. This is the child is breathing. This is the child is breathing, and it stops. Suddenly stops. This is the saturation. It stays maintained above 90. Remember, the 90% I said is equivalent to 60 millimeters of mercury. Everybody knows that, yes? There is a lag period, and then the saturation starts to go down. Yes, it goes down. Heart rate was stable, and suddenly there is bradycardia. This is a significant event. If the child is 40 weeks or older, this may happen on a periodic basis. Here it is, the child's having apneas, breathes, apnea, breathes. This is called as periodic breathing, by the way. Heart rate goes in, up and down, up and down, up and down. Needless for me to say that this can lead to SIDS, sudden infant death syndrome. Everybody knows that. Yes, periodic breathing, apnea of prematurity above 40 years of age is a very significant event, needs to be looked into. Okay, what are the causes? Can be very simple that the child has sepsis. He may have thyroid disorders. He may have bleeding in the brain. May they have hypoglycemia. They may have cardiopulmonary developmental abnormalities, things like that. The differential diagnosis is long, as I say. So apnea of prematurity that persists should lead to the development or lead to investigation of this kind. If everything is negative, sometimes the pediatrician will also give caffeine because that helps with the development of the respiratory center. Most of these kids get better on their own if everything is okay, by 3 months, all kids are fine. Unless and until they have some developmental problem that will need to be looked into. Apnea of prematurity starts, the child is born premature, less than 40 weeks. Generally, it's as the child grows, and these kids are observed in the nursery, they're not sent home. As the child the development occurs, respiratory center becomes more mature by age of 40, 41 weeks. Everyone is fine, they can be discharged. If there's still a problem, these kids are sent home with apnea monitor. I hope you know that. Most will be absolutely clear. If they have no developmental abnormality, they will be fine at 3 months of their post-gestational age. If not, investigations continue. On the other hand, apneas in adults is a totally different ballgame. That also means cessation of breathing for more than 10 seconds. Apnea in adult means cessation of breathing more than 10 seconds. And this is how it occurs. We have talked about how the lung develops. Everybody remembers that or no? Yes. When the lungs develop, the upper airways does not have a cartilage. There's tongue in front, there is pharynx, larynx, esophagus, trachea. Okay, larynx leads to the trachea. Yes, the upper airway does not have a cartilage. Does not have a cartilage. So when we fall asleep, stop writing. Stop writing. I want you to think of sleep and wakefulness as two levers of a car. You understand? If you're awake, you're not, you can't be asleep. If you're asleep, you can't be awake. Yes? Can be awake and sleep at the same time? Yes. And we both think are off only at time of death. Yes. Yes.
Yes.
Okay. So how do we fall asleep? Sleep is divided into two parts. Light sleep, deep sleep. Yes. Light sleep and deep sleep. The light sleep is a time when somebody wakes you up, you would remember next day. Deep sleep, if somebody wakes you up, you wake up, you're confused, you go back to sleep again. Chances are you're not going to remember next day. That's one way to look at it. But EEG recordings are different. When you're in light sleep, the rhythm is in totally different kind. When in your deep sleep that I'm talking about, you have a different kind of EEG rhythm. Is everybody with me on this? Yes?
Yeah.
Accompanying this deep EEG rhythm is our muscular activity. When we are in light sleep, we are moving. When we are in deep sleep, we are paralyzed. We are paralyzed. We are paralyzed because we dream. And we dream, we don't want to act out our dream, so body is paralyzed. This is true. Yes? In your deep sleep, there are only 3 muscles which are active. 3 skeletal muscles which are active. One, your diaphragm. You still need to breathe. Yes? Your eye movements. That's why deep sleep is also called as rapid eye movement. Make sense? And third is the middle ear activity, because that we have acquired when we were animals. Because if you look at animals when they are asleep, their middle ear activity is very good because that's a flight and fight reaction. That's how animals pick up the danger. So we have lost that. Our middle ear muscle is less active, but is still active. So 3 muscles, 3 skeletal muscles which are active in deep sleep are your diaphragm, is your eye movements, and your middle ear muscles. The rest of the body, legs, arms, this, that, paralyzed. Yes? So let's look at this way. When you're in a deep sleep, the muscles are paralyzed. So is tongue and the jaw. Yes? If I take a cut section of my upper jaw this way, and the tongue is like this. Yes? Yes?
Yeah.
You lie down, supine, tongue falls back. Yes? In some, this will completely obliterate the airways. Yes?
Yeah.
If it does that, there will be cessation of breathing. Yes? If there is cessation of breathing, slowly the oxygen level will go down in the body. Yes? When that's happening, the body sends signal to the respiratory center in the medulla oblongata. Hey, what's going on? This oxygen level is low. Yes. Suddenly the person breaks out. That's what the snoring cycle is. When you're snoring, these muscles are rattling, 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 and stop. Stops for a while till the time the receptors in the chest wall send signal to the brain that there's no oxygen coming through, and you wake up. When that happens, when this thing happens, it also causes something called as micro arousal. Micro arousal. Micro arousal means EEG rhythm changes, but you are not aware of it. You are still asleep. The person who has sleep apnea is still asleep. But if you have this happening every 30 seconds of your entire night, you really are not sleeping. You understand? If you're not sleeping, you fall asleep in boring lectures like this. When you're not sleeping, you take your leg off from the paddle at the red lights and cause accidents. Patients who have this thing going on every time in the night, they have high incidence of diabetes, they have high incidence of hypertension, they have high incidence of atrial fibrillation, high incidence of sudden death, high incidence of cancer, high incidence of diabetes, high incidence of poor performance on PA school exams, and things like that. That was a joke, please disregard it. At the point you got it, right?
Yeah.
Sleep apnea is a real issue. And it is very simple. It is a physiological response. And here it is. This is the tongue of a regular person, but it is the genioglossus, which is the tongue muscle, and the uvula, and this area I'm talking about. In deep sleep, tongue falls back, uvula falls back, and this area closes. When this closes, there is no cessation. There is cessation of air, so there is no gas exchange. If no gas exchange, patients become hypoxic, they stimulate the brain wakes up. So essentially, the brain never gets any rest in the night. So what you need to know is that deep sleep is the time when we process our memory. We process the memory and make it into RNA. The reason why you remember your name and your relatives' names and your birthday and things like that, because some of that information has been converted into an mRNA and put it into your cerebral cortex. And the reason why you don't remember people who stood next to you in LIRR is because that information is processed out every time in the night. The superfluous information, boring information that I'm giving to you tonight will be filtered out in your REM. The important information is processed. So those patients who have sleep apnea, they are waking themselves up every 30, 40 seconds. They are not processing information. In fact, this is a concept dementia. Okay? They have to tell you the sleep apnea is actually 5% of the population, more common in males. If this 5% of the population, this class is what, 25 people, 40 people? How many people are there in this class? 35, 5% of the population, 1.5. At least 2 people have sleep apnea. It looks like more than that from my observations. Point well taken. Sleep apnea is very common. You understand? And it is easily treatable. And how do we treat it? This is what I'm talking about. We treat it with a positive pressure ventilation. What are the risk factors? Obesity. As we gain weight on our abdomen, our neck size also increases. If your collar size is more than 17, you are at risk for sleep apnea because the fat around the neck presses on the pharynx. And remember, it has no cartilage, so it gets compressed. If it gets compressed to begin with in the night, those who have things like this, they are able to save themselves. You start with like this, we're more at risk for sleep apnea. Age. As we age, sleep apnea increases. After 30, everything is downhill. Craniofacial anatomy. If you are opposite of Jay Leno, the jaw is not pushed forward but pushed backward. 15% of population has micrognathia, means the jaw is not very well developed. They are at risk. Premenopausal. is protective. The fate is protective because progesterone keeps it open. Later on, women catch up. So this 5% also is true for postmenopausal. What is the most common presenting symptoms of sleep apnea? It's not snoring. It is excessive daytime sleepiness. Excessive daytime sleepiness. The most common presenting complaint of sleep apnea is excessive daytime sleepiness. What is predictive 100% of apnea is bed partner informing witnessed apneas. If somebody has watched you having his breathing or her breathing becomes shallow, that has a very high predictive probability in terms of predicting sleep apnea. Okay, excessive daytime sleepiness, the most common complaint, most common complaint and most predictive of sleep apnea is a history of witnessed apneas. Snoring may or may not ultimately result in sleep apnea, but you're on that train. Keep that in your mind. Mild, moderate, severe, you're on that train. And how do we predict? And this is something all of you should know. I don't care whether you do pediatrics, GYN, orthopedic. I don't care. I want you to know this. This is called as Mallampati score. Mallampati score. It predicts probability of successful intubation also, but it also predicts sleep apnea. Ask the patient, stick their tongue out and say, do nothing, just look inside. If you can look at the posterior pharynx, that's good. If it's like this, 2. If it's minimal scene 3, and you can't see the posterior pharyngeal wall, that is Mallampati score 4. Mallampati score 4 has a very high predictive value in predicting sleep apnea. So here's a clinical exam which can tell you whether the patient has sleep apnea or not. It is important because all patients who go for surgery under general anesthesia should be screened for this, because if you have sleep apnea, you get intubated, you will have a hard time coming off the ventilator. You don't want that to happen. So how do we diagnose sleep apnea? We just used to say polysomnography, which is an in-lab study, but nowadays we also are doing something called as home sleep testing. Let me take you to the polysomnography. Somebody's asking something on the chat. I have no idea what that is.
There's nobody on Zoom.
That's all it is?
Oh, there is.
Okay, so now I lost the slides. What do I do? Oh, what did we do?
Oh, somebody's on.
Okay. How do I get my slides back? This. Oh. Okay, so the best way to diagnose sleep apnea is something called as polysomnography. Let me go through this. Polysomnography is EEG, belts on the chest, belt on the abdomen, and some leads on the leg. But let's see what it is. The belt on the chest will tell you the respiratory effort. EEG is the EEG. Saturation is the oxygen saturation. So this patient's having apnea means his tongue fell back, apnea. Look at the respiratory effort. It is more. Keep going. And then suddenly he forces himself out because of the brain thing. It suddenly opens up and airflow is re-established. There was no airflow here. Saturation, which was going down, suddenly starts to up. What is troublesome is, while this happens, your EEG suddenly shows a little bit of wakefulness. This micro arousals are detrimental to health. If you have a lot of micro arousals, you never slept, your brain will be sleepy in the morning. That's why you're groggy, you need more oxygen, you feel tired. If you wake up in the morning and feel tired and fatigued, you have had micro arousals in the night and you've not slept well. You can also nowadays, instead of such a detailed thing, we do home sleep testing in which patients get a pulse oximeter and a device in which we can measure if they have sleep apnea or not. I've already talked about the comorbidities of this: hypertension, heart failure, stroke, increased motor vehicle accidents, depression, etc., are all related to OSA. Treatment is a positive pressure ventilation, which is this. You put a mask on to see there is a complete occlusion here. Now with the positive pressure, the airway is established. The best treatment of sleep apnea is positive pressure ventilation. Those who can take it, they can get surgery done, which is mandibular advancement. Orodental device to move your jaw forward, which opens up the space on the back. Nowadays, we also, as part of the treatment, give them GLP-1 agonists for weight loss, which is now a recommended treatment in addition to CPAP for these patients. Few other things that we do is called as hypoglossal nerve stimulation, in which there's a pacemaker-like thing established, put placed in the anterior chest wall with a lead at the near the tongue. Second lead is near the diaphragm. Every time patient starts to take a deep breath in and close, this thing starts to close airway. It gives a stimulation for the genuglossal and it moves forward. It contracts and moves forward. The airway's patency is maintained. So hypoglossal nerve stimulation is another way of looking at it. Make no mistake, positive pressure ventilation is the best treatment. It prevents all complications. Hypoglossal nerve stimulation, we talk. Let's keep moving. Stridor. Shortness of breath, we talked about. Let's deal a little bit of stridor. What is stridor? Stridor is the inspiratory sound. It's the inspiratory sound. If it's an inspiratory sound, it is above the vocal cords. Stridor is a problem above the vocal cords. Okay. Many causes for this. Most common cause of stridor in the first 3 months of life is laryngomalacia. The larynx hasn't developed properly. The typical histories, parents will bring the child, they say when they put him on the shoulder, no stridor. Put it supine, stridor. Shoulder, stridor, no supine, supine stridor. Most of this gets better on its own. Very few children require any surgery for that. But stridor is generally inspiratory. It will start inspiratory, and if the underlying disease process continues, it will become inspiratory and expiratory. Okay. Stridor always starts inspiratory. Second thing, stridor is something that you can hear from your ear. What are the causes? Supraglottic, glottic, and just subglottic. Supraglottic means above the vocal cords, glottic at the vocal cords, just below the vocal cords. The ones which are important for you, I have highlighted them in English in yellow. Sorry. I speak 5 languages. English is my 5th language. I speak 5 languages. Yes. So if I make a mistake, it's okay. All right, it's the end of the day. Supraglottic is epiglottitis. Inflammation of the epiglottis can cause stridor. It's an infectious disease. We'll talk about that. Another thing that is important, at least in this part of the world, is recurrent respiratory papillomatosis. This occurs with stridor at the time of birth. It is a viral infection, okay? Comes from the birth canal and child gets it, and you get papillomas on your vocal cords, and the child is having stridor, okay? Needless to say, foreign bodies stuck and in 2 to 5 years of age in children will cause stridor. Subglottic tracheal stenosis or laryngotracheomalacia, an infection caused by viral infection, can also cause this. So many causes for stridor, depending upon where the location is, acute and chronic causes. So let's look at a few of these. Laryngomalacia occurs in the first 3 months of the child's birth. Child is erect, the larynx is open, no breathing, no problem. Supine, larynx closes, stridor. Most of it gets better as the child grows on its own. Sometimes surgery may be needed. Some of the other patients may have recurrent laryngeal nerve problems. If the vocal cords are not functioning, child will have stridor, and that needs to be looked into. It can be from many other things which are pressing on the airways as well. This is the papillomatosis that I talked about. HPV1 and 11 are the cause for stridor in kids, not kids, in infants. Sometimes children may have webs, sometimes may have spasms, sometimes in adults we may have granulation tissue and Wegener's granulomatosis. I'm looking inside a patient's trachea. These are the vocal cords, and this is the stenosis. This also is a stenosed area. This is from post-intubation. Multiple intubation can cause damage in the subglottic region. The person gets stenosis. And lastly, scar formation. Again, this is the one vocal cord, second vocal cord. Below the vocal cords, there is a web formation, means there's something web like that. So many causes for this. And in children, particularly hemangiomas of the neck, this is a child with hemangioma. You see the tracheostomy, and you look inside, the hemangioma is pressing on the airways. And subglottic cysts in the neck again can be pressing onto the airways, causing all kind of striders. We all agree, stridor needs to be taken seriously. Never send away a child from stridor from the ER. Please don't take it on yourself. Some infections which cause this, we'll revisit that again. One of them is bacterial tracheitis. Bacterial tracheitis is from staph. Generally, child will have a high fever, chills, rigors, and stridor as well. Toxic looking child will require antibiotics, and sometimes CAT scan or bronchoscopy may be required. This is one of our own patients looking inside the trachea. This is the carina, right main stem bronchus, left main stem bronchus has been cleaned of the secretion. So bacterial tracheitis is a bacterial infection where it causes so much inflammation that the child may have a stridor as well. Second one is croup, acute laryngotracheobronchitis. Laryngotracheobronchitis, larynx, trachea, bronchus, everything is inflamed. This occurs generally in a younger child population. Parainfluenza viruses. Generally, most children are playful even when they're having croup. It may be confused with epiglottitis, and that needs to be looked into. Epiglottitis is a bacterial infection from H. influenza B bacteria. You will have on a neck X-ray inflamed epiglottis. You can see, or on a CAT scan, you can see. One thing, if you suspect epiglottitis, please do not do the tongue exam. Do not try to look inside the child's mouth, because if you touch it, the epiglottis is behind, it will sit on the vocal cords, it will close it, you will not be able to intubate the child. So if you think of epiglottitis, ask for help from anesthesian. Do not do the oral exam. Don't be that aggressive in children if you suspect epiglottitis. What I'm saying is, if you see children with stridor, I forbid you from taking a spatula and trying to look inside. Two things. One, if it's epiglottitis, you will cause a problem to the child. And secondly, if child has a foreign body, you may push it further. Don't do that. Do not do that. Ask for help, okay? These are the differences between the two. We'll come back to that when we do upper respiratory tract infections in the same slide there. A few other causes of stridor is a retropharyngeal abscess, abscess behind the pharynx. Now, this is not commonly seen in this country, but tuberculosis of the cervical spine can cause a cold abscess there. And that abscess, this is the spine, that abscess can press on this and cause stridor. So not in this country, but I've seen it. It does occur and cause stridor as the first presentation. This was in fast view of stridor, and I hope I've scared you people enough not to mess with stridor, but ask for help and to see. We will be very careful about foreign body and stridor. In foreign body, the child is listless, drooling from the mouth, emergency. Ask for help from anesthesia and things like that, because the foreign body needs to be removed. Epiglottitis, generally an elderly man, elderly population, or teenage 10, 11 above people. We will not do oral exam in those patients because you may end up harming them down the line. Is everybody with me on this?
Yeah.
Okay. I talked about the foreign bodies and unilateral wheezing. Now, wheezing is usually bilateral. If it's an airway problem, it has to be bilateral wheezing. What if it is unilateral? If it is a unilateral wheezing, either it is foreign body in the area, or there is a tumor in the area, or there's a blood clot in the area. Unilateral wheezing we'll have respect for. Always unilateral wheezing is pathological and always bad news for the patient. Either there is foreign body, or this tumor, or there is a blood clot. These patients will require bronchoscopy. Okay? Unilateral wheezing, send it to a pulmonologist. Foreign body, this is one of my patients with a crown stuck into their airways. Okay. Lastly, chronic aspirations and blockage can result in bronchiectasis in that area. This is one patient. Take it from me, has right lower lobe collapse. On the CAT scan has these findings, which is take it from me, suggestive of bronchiectasis. So chronic foreign bodies, aspirations in one region of the lung will ultimately lead to bronchiectasis formations in that area. Okay, we did that. Other causes of recurrent wheezings, asthma, aspiration, foreign body, etc., etc. Okay. Let's look at the other things which affect patients with our patients with pulmonary problem. Need to look at hands. If you look at patients' hand, you can get 80% of their lung problems. Trust me. I do that all the time. Clubbing gives you an idea what is happening to the patient. Presence of clubbing in which the angle of the nail is obliterated. It occurs in suppurative lung disorders, bronchiectasis, or in patients who have lung cancer, or in patients who have interstitial lung disease, pulmonary hypertension. I'll repeat one more time, COPD on its own does not cause clubbing. COPD with clubbing means patient has lung cancer, or COPD with clubbing means pulmonary hypertension. COPD clubbing can also occur extra pulmonary problems, particularly inflammatory bowel disease, Crohn's disease, etc., or liver problems, cirrhosis of the liver. Clubbing with cyanosis occurs with congenital heart disorders. Knowing a little bit about them will always be a good thing. What about nasal polyps? Nasal polyps nose exam is also a part of pulmonary examination. Presence of nasal polyp also tells you what is happening in the nose is happening in the lung. Just think of it this way. The patient has nasal polyps bilateral, always rule out systemic lung problems as well. It can be as simple as this, in which patient has, these are the polyps on the nose, and patient's heart is on the right side of the body, not on the left side, which is the situs inversus, which along with sinusitis and bronchiectasis, it results in what is called as Cartagena syndrome. In Cartagena syndrome, patients' cilia are not functioning properly. They have a ciliary defect. This is primary ciliary dyskinesia, may be present in these patients, etc., etc. Okay. Diagnosis is based on electron microscopy of the nasal mucosa. Of these things, they have each of these cilia, not going into details, have a dynein arm, which is defective. These are things, you see these clips that they have. They're lost in the patients with primary ciliary dyskinesia. We'll visit that again. Lastly, what about hemoptysis? And we visited hemoptysis in the first lecture when we talked about the causes of hemoptysis. And I gave you an acronym as well. And we talked about that anticoagulation, bronchiectasis, lung cancer, etc., are common causes of hemoptysis. And worldwide, we agreed. Worldwide, the most common cause of hemoptysis was tuberculosis. Everybody's remembering that? Yes? All these are exam questions, by the way. Okay, so hemoptysis can also occur from AVM, arteriovenous malformations in the lung. That syndrome is called as Osler-Weber-Randu syndrome. Osler-Weber-Randu syndrome. Now, this is a condition in which there is a genetic defect, okay? There's a genetic defect. These patients have telangiectasia in the mouth, in the lungs, in the nose, and the brain. One more time, in the mouth, in the lungs, in the nose, and the brain. If it's in the nose, these patients have epistaxis. They bleed from the nose. If it's in the mouth, they will cough out. They'll tell you while brushing my teeth, I don't know why I bleed. And this is the patient. As you can see, there are millions of AVMs on the face. Let me point them out to you. This. All of these are arteriovenous malformations. If it is in the mouth, it's in the lung. And if it is in the lung, this patient will also present to the ER one time or the other with coughing or blood. That's a very important sign, rather dangerous sign, right? And if it is in the lung, chances are it's in the brain. And if it's in the brain, some of these patients present with seizures. But this is what you need to know. If your patient has an AVM in any of these areas, you must scan the brain because it may be silent. Okay, all these patients must get a brain MRI to look for arteriovenous malformations. Secondly, these patients are at risk for abscess formation, so they should get bacterial endocarditis, prophylaxis if they go for any surgery, cholecystectomy, hernia, all those kind of things that they go for. It is because it's an autosomal dominant disease, chromosome number 9 problem, long arm of that. Just to remind you, it is from an activin and endoglin problem, these are the genes which promote, rather code for blood vessel development in the body. If these genes are defective, patients are at risk for having AAV malformations of the body. So many of these, as I talked about, if it's in the lung, what do? If it's in the brain, we embolize. If it's in the GI tract, we embolize. If it's in the lungs, we embolize too. And we can embolize by doing same bronchography, going in, and this is the AVM, it can be obliterated. This is an AVM, it can be obliterated. If embolotherapy is not possible, there is a treatment for it called as bevacizumab that can be given to these patients as well. So the treatment of AVMs is very far advanced, and most of these people can have a near normal life once it is diagnosed, then they live completely normal life nowadays. I think causes of nasal polyps, we talked about it. Cystic fibrosis, allergic fungal infections. I talked about cardiac syndrome. I do also want to point out something that you may or may not have thought of it, aspirin intolerance. If you're aspirin allergic, if you have aspirin allergy, who's not an aspirin now? Most of the world is on, but if you have aspirin allergy, you will develop asthma, you will develop nasal polyps. This is called a Samter's triad. Oh, okay, so bronchial asthma patient who has bilateral nasal polyp, you will ask for the history of aspirin allergy. Bronchial asthma patient who has nasal polyps, you will ask for a history of aspirin. Thank you. Okay. One more thing which should be clear to patients is called as erythema nodosum. What is erythema nodosum? Erythema nodosum is inflammation of the subcutaneous fat. Inflammation of the subcutaneous fat. It appears as blackish spots on the shin of the tibia, and it will come in the exam. Erythema nodosum can occur from infections. Children who get repeated strep pharyngitis get it. By the way, it can be normally present in pregnancy as well. Why do we get excited in pulmonary medicine? Sarcoidosis is associated with erythema nodosum. Pulmonary coccidial infections are associated with erythema nodosum. The ones which are important, I have highlighted them, made them yellow for you to remember. How do these patients present? This some doctor, there's some little brownish pigmentation on the shin of my tibia, and it is tender. It is tender on touching. That's all. And sometimes patients will come back and say they come and go. A lot of them have underlying collagen vascular disorders, etc., etc. Sometimes we can't find a cause. In fact, the commonest cause of erythema nodosum is idiopathic. We can't find the cause, but you will, if patient comes to you, you will look for sarcoidosis, you look for coccidioidomycosis, you look for pharyngeal infections. Obviously, pregnancy is a totally different ballgame. You should know that. So I've taken you a whirlwind tour of what are the various presenting signs, symptoms, diagnosis of all pulmonary things. Maybe we can stop at this point of time because I'm not getting a visual cue from you people. But first 4 lectures are important. It's a gist of what every healthcare person must know.